giving a remedial exam because if not, the two people will not progress further in the module. So I'll talk to the LO later and give a link for another exam for two of your classmates. So today we will be having a lecture on the ophthalmic history and physical examination, which will be graded using a video on Tuesday. So as seen in your groups, I posted some instructions on what to do so that later on we will be discussing on how or what cases you would have to do. Please be reminded that this is really graded and you have to do your best here because I already failed two groups last time. And if you fail, the group may consist of around 25 to 30 students, and it's a group grade. So if your group fails, all 30 doctors or students will fail. So please make sure you do good here. I'll be starting. So good morning, everyone. Again, I'm Dr. Paulino, and this is the last time that we will be encountering each other. This will be on the ophthalmic history and physical examination, and will be graded on Tuesday next week using a 10 to 15-minute video. So this is the outline of the presentation. It might look long here, however, it's not that long when we discuss it. So it will be comprised of the ophthalmic history and the physical examination. We start with the ophthalmic history. So the ophthalmic history starts with us asking the chief complaint of our patient. So it may be the main reason for the consultation. And there are times that patient may have multiple problems. However, we should always focus on the immediate reason for the ophthalmologic consult. So please make sure to get the main problem first because patients may have problems with their vision and then later on they will tell you there's something wrong with their eyelids or some itchy feeling. So please make sure that you get the main reason for the consult. As mentioned here, it may be vision related, which is the most likely reason for them to see you. However, there are times that it may be because of pain or abnormality in appearance, such as eye redness, or the patient may have trauma. And it's the reason why they came to you because there's a foreign body lodged in their eye. The past medical history is the next part of the ophthalmologic history. You have to ask them if they use eyeglasses or contact lenses and the date of the most recent prescription because it may be the reason for their main problem. So people might come to you and tell you that they have blurring of vision. However, you weren't able to ask them if they wore glasses before or they had surgery or ocular medications in the past because patients may come in for consult because of eye pain but you weren't able to get it in the history that they have glaucoma. So please make sure that you ask their ocular history and also medications. Surgeries, including laser surgery, might confound your findings. So please make sure that you elicit it always. Also, a history of trauma could cause blurring of vision and corneal warpage, and also the history of amblyopia or of ocular patching in the children or during childhood, because this may be the reason why you can see the patient not improving even if you give the optimal glasses or prescription. It's because the patient developed lazy eye or amblyopia. So it's very important for you to ask that. Focusing on ocular medications, we need to know how the patient responded to prior therapy, especially on patients with glaucoma, because we do not usually repeat a medication that shows no effect for the patient. So we have to know the recent therapy within the past 6 weeks because it can affect the patient's present status. So unlike other medication which only affects 3 to 5 days, ocular medications may persist. It may also be the cause for toxicities and allergies in the ocular adnexa, the cornea, and the conjunctiva. Also, you have to ask what kind of medication or brand because other formulations may have different concentrations. Moving further, the general medical and surgical history. So after asking the medications, we have to know what the patient dealt with ophthalmologic wise. There are many ocular diseases which are associated with systemic diseases such as diabetes, hypertension, such as the one seen in the upper right of the slide. This is a picture of diabetic retinopathy with concurrent hypertensive retinopathy. So as you notice, there are streaks of blood or blood clots on the retina near the blood vessels and also those exudates. The exudates emanate in a radial pattern on the area of the macula. And later on, you see that there is a soft exudate or cotton wool spot on the inferior vascular arcade. Also, we have to know the general medical status before we perform a preoperative or a pre-op evaluation for surgery. If you notice on the lower right of the screen, there is a patient with exophthalmos. So prior to doing the operation, you have to know how the thyroid functions are and the correct measurements. So the general medical status can actually tell you if the patient can be operated or not. Because there are times wherein the patient has poor status wherein it may cause a very complicated operation and also recovery, since there are times that when we operate, we have to place the patient under general anesthesia. If the patient is not optimized, it may cause the patient to have complications or even death on the table. After asking the past medical history, we should also ask for the systemic medications. There are systemic medications which cause ocular, preoperative, intraoperative, and postoperative problems. It can also provide clues to systemic disorders that the patient might have. There are times that the patient do not know that they have uncontrolled hypertension because they see that their blood pressure are okay at certain times of the day. However, the patient's already on 3 to 4 medications. So we know that the patient may have very, very high blood pressure. And this may cue us in looking at the retinal vasculature. And also, it could tell us that the patient has already long-standing condition. We have to give particular attention to the use of aspirin and other anticoagulant agents because this would have long-term effects on our management, especially if the patient has retinal bleeding or will undergo operation. As you can see on the lower right part of the slide, there's tamsulosin. Tamsulosin can complicate cataract surgeries because it may cause floppy irises. So usually, when we do our ophthalmic history and systemic medications, there are specific medications such as this tamsulosin and also um, uh, beta blockers, especially if the patient has asthma, because beta blockers such as timolol may exacerbate asthmatic attacks. So we have to make sure that we know all the medications that the patient have. We also have to ask for histories of allergy. So as mentioned a while ago, patients with asthma and allergies can react with timolol or beta blockers. Also, since there are times that the patient will come to you because of eye redness and itchiness, you have to always associate that with possible allergies to dust, to inhalants, and contactants. So allergy to contactants may be because of the eye drops, or if the patient rubs his or her eyes so much, it would cause allergies and rubber. Also, if the patient has food allergies because it may be the reason why they have recurrent allergies or eye redness because they keep on eating shrimp, eggs, or any shellfish. This may be a long list of family history. However, all of these will help us in getting the problem. So sometimes patients might come into your clinic because they have headaches that are one-sided. And as ophthalmologists, we would always think of glaucoma first. However, this may be migrainous. So most of the time, patients with migraine have a family history of that. Also, retinitis pigmentosa. If the patient tells you that his or her parents have night blindness and tunneling of vision, it might point you to retinitis pigmentosa because this is hereditary. Also, retinoblastoma. Findings say that patients with retinoblastoma and also their offspring will have higher chances of developing, especially binocular retinoblastoma. Color blindness usually happens among males in the family. Nystagmus also. Albinism, children of albinos may have higher chances of developing albinism. It may not manifest in the skin, but ocular albinism, where we see that the retina is hypopigmented, may happen. Other conditions such as sickle cell anemia, choroideremia, keratoconus, Marfan's, diabetes, and hereditary macular degeneration should also be asked. So that was only the ophthalmic history. So it's very fast. The actual bulk of what we're going to talk about is the physical examination. The physical examination would also be the one that we will be focusing on for the OSCE video. So the ocular examination may be grouped into 5 main tests plus the visual field examination. If you notice, this is more than 6 because the gross eye examination also includes the pupillary exam. But we have to focus on the pupillary exam for a separate slide. That's why I put it there. So we start with the visual acuity testing. Most of the time, our patients come in for blurring of vision. So we have to quantify what the patient sees because we don't know what the patient came with, and if ever we treat, we have to know how much improvement or worsening would happen. So when we do the visual acuity testing, we use tools or visual acuity charts. Usually we use the Snellen chart, which is available to everyone. The ETDRS chart is what we use for researches. Picture charts are for those who cannot read and for children. And it may be, if we don't have any charts, we may use our fingers, certain lights, and objects. So we must remember that each tool or chart has its own procedure of use and reporting. Because like the Snellen chart, you have to put it 20 feet away from the patient. Such other charts, such as the ETDRS, should be placed 2 meters away from the patient. Picture charts, such as the Leia chart, should be 10 feet away. But for our lecture purposes, we will use the Snellen chart. I will explain this in a while. So the visual acuity testing will tell us for possible errors of refraction. As based on our lecture before, refraction is a result of the cornea, which is 2/3 the power of the refraction, the lens, which is 1/3 the power, and the retina, which is represented by the axial length. This may be done for distance and near vision. However, if a patient goes over 40 to 45 years old, we must test both the distance and near vision because the near vision will be affected by a condition called presbyopia, which means they may have very good vision at distance. However, because of their aging lens, they lose the ability to accommodate. So they may have 20/20 vision at distance, but their near vision is 20/200. So that you have to make sure to test both distance and near vision for patients who are older than 40 to 45 years old. As mentioned a while ago, age and condition dictates what method or tool is appropriate to use. Because you do not expect babies to read the ETDRS chart or the Snellen chart, you have to make sure that they'd be able to understand the test or chart that we will be using. Also, for patients who have very, very poor vision, we cannot force them to read the Snellen chart. Sometimes also we just use a pen light if they can see the light or not. Moving forward, the specific test that we are going to do for the OSCE is the Snellen chart. So seen here on the right side is a standard Snellen chart. We ask the patient to stand 20 feet away from the Snellen chart when we are testing them. To avoid confusion, let us always test the right eye first before the left. However, this is not written in any book. I just want everyone to make sure that they do this so that they will not be confused. Because if you have a lot of patients, you might confuse yourself or the person you are reporting to. So let's always take the right eye first before the left. It is important for the patient to not put pressure on the eye that they are covering. Because if you notice, when you fall asleep in class and you press one eye, it will blur the vision. So as not to make us get improper values, make sure that you do not put pressure on the patient's eye. If the patient covers his eye, make sure that the hand is cupped over the globe. Because if you put it flat, it may put pressure on the eye, or if you put your fingers or the fingers of the patient to cover the eye, they might see through the small holes, giving erroneous results. So please make sure they use their cupped hand over the left eye or the eye that's not being tested. We ask the patient to read the letters from biggest to the smallest. So if you notice here in the Snellen chart, the biggest letter is the letter E, which gives us a visual acuity score of 20 over 200. So if you wonder why the numerator is always 20, because that is what the patient sees. Remember, the patient is 20 feet away from the Snellen chart. So if the patient sees the letter E at 20 feet away, that is 20 over what a normal person would see. So a normal person would see the letter E at 200 feet away. So that's why if the patient, the one we're assessing, who is 20 feet away, can only see the letter E, the numerator is 20, but the denominator is 200 because a normal person could see the letter E 200 feet away. If the patient can read the letters D, E, F, P, O, T, E, C at 20 feet away, that means the patient can see what a normal person could see because the octotypes or the 8th line, which has the D, E, F, P, O, T, E, C, is what a normal person could see at 20 feet away. So if you notice, there are a lot of letters. The way we record it is that based on what they can see, so imagine if the patient can read the letters T, O, Z, that will give us a score of 20 over 70. However, if the patient makes a mistake, if the patient can only see the letters T and Z, we score it 20 over 70 minus 1. So make sure to get the majority line correct. So if the patient can only read the letter T, however, the patient can read the letters F and P, then the score will be 20 over 100 plus 1. Okay? It will only be a problem if the letters are in a even number because there would be a possibility of 50-50. So if the patient can read the letters L and P, instead of saying 20 over 70 plus 2, the more correct answer is 20 over 50 minus 2. So get the higher score. So instead of 20 over 70 plus 2, which is incorrect, the correct answer should be 20 over 50 minus 2. Okay, does anybody have any questions regarding that? So if there are no questions, I'll move forward. So, for example, we have a patient in our OPD. So we have to ask the patient first if he or she wears glasses or not. Since if the patient wears eyeglasses, if the patient does not wear any eyeglasses, we have to check only the uncorrected vision and the vision with a pinhole. So a pinhole is an instrument which we use that has a small hole around 1.5 millimeters, which we use to cover the eye. So when they cover the eye, they only see through a very small hole. As mentioned in our lecture before, the pinhole concentrates the amount of light and hits the macula. So the macula is the center of the retina, which has the most concentration of cones. So if we put all the light through that small hole, it will focus directly on the macula, which eliminates the errors in refraction caused by the cornea or the lens. However, if the patient wears eyeglasses, we will have to get the vision with uncorrected, which is SC, CC, which means with correction or with the patient's eyeglasses, and CCPH, which is the corrected vision with the glasses and a pinhole over it. Because it is very possible that if you put eyeglasses over the pinhole, if you put the pinhole over the eyeglasses, it may still improve the vision. So that's how we do it. For example, you have a patient and the patient does not wear any eyeglasses. You tell the patient to stand 20 feet away from the Snellen chart and tell the patient to cover the left eye using the left palm. And the patient can only read the letters L, P, E, and D. So, as was mentioned a while ago, we will score the vision as 20 over 50, corresponding to the score of what the patient can read. So since we are not satisfied with the patient's vision, we pull out a pinhole and put it on the right eye. So putting the pinhole on the right eye, we get a vision of 20 over 20 minus 4 because the patient can read the letters D, E, F, and P. However, the patient cannot read the letters O, T, E, and C, making it a mistake. So since the line has an even number of optotypes or even number of symbols, we get the higher score, which is 50-50. So DEFP, that's 2020 minus 4. Okay? Clarification again, we do not get the score of 20 over 25 plus 4. Rather, it should be 20 over 20 minus 4. So, for example, again, we have a patient with eyeglasses. So we do the same thing. We tell the patient to stand 20 feet away from the Snellen chart and we ask them to cover their left eye. So when doing this, the patient was able to read the letters F and P, giving the patient a score of 20 over 100 for the right eye. We then ask the patient to wear his or her eyeglasses. So upon wearing the eyeglasses, the patient's vision improved to 20 over 30. However, it is still not 2020. So you're thinking of the possibility that the patient may have undercorrected eyeglasses. So we tell the patient to put a pinhole over the eye with the eyeglasses or the right eye. And we get a vision of 20 over 20. That just means that the patient has undercorrected vision and would benefit from having newer eyeglasses. So what if the patient cannot see the letter E at 20 feet? So the patient might come to you and tell us that we have blurred vision and does not improve with eyeglasses. So since the patient cannot read the letter E at 20 feet, we ask the patient to move closer to the chart and until the patient can only read the letter E. So please remember that it is only the letter E because if the patient can read other letters, then we would not have any comparison for other people. So for example, the patient can read the letter E at 10 feet away from the Snellen chart. So the patient's vision would be recorded as 10 over 200 because the numerator is the distance by which the patient can see, and the denominator is what the normal patient could see. Since we will use the letter E as basis for the vision, then everything that the patient, all patients who cannot see the letter E at 20 feet will use the letter E as basis. So if the patient can read the letters F and P at 20 feet away, if the patient can read the letters F and P at 10 feet away, we have to ask them to move backwards until they can only see the letter E. We do not record it as 10 over 100. We should make sure that the patient will only read the letter E. The moment the patient moves forward from the 20-foot mark, the denominator will automatically be over 200 because the letter E will be our basis. Okay, does anyone have any questions up to this point? No question.
Excuse me, doctor, can you repeat the last line that you mentioned, please?
Um, that if the patient cannot read the letter E at 20 feet, they move forward until they can read the letter E only. Once they read the letter E, the numerator will be the distance from the Snellen chart, and the denominator will be the letter E with a score of 200. Okay? So always, if the patient moves forward, it will be recorded as over 200 because it will be the basis, the letter E. The only thing that will change is the numerator. If the patient can read the letters F and P at 10 feet away, move them back until they can only see the letter E. We cannot have a score of 10 over 100. Rather, make them move backward until they can only see the letter E, such that if the patient can read the letter E at 15 feet away because we let him move back, it becomes 15 over 200. Okay, is that clearer?
Yes, doctor. Thank you so much.
Okay, moving forward. If the
Doctor, one more
patient,
doubt.
what?
Doctor, suppose if a patient is able to read the seventh line, but he misses out one or two alphabets, like instead of E, he pronounces it as F. So what do we do about that then?
Then it becomes 20 over 25 minus 2. So as mentioned a
Oh,
while ago, you have to have majority correct. So if it is more than 50% of the line, you just minus the number of mistakes. So if the patient has a mistake with the P and Z, the score will be 20 over 25 minus 2.
okay then. Thank you for
Okay?
yes, sir.
So moving forward, the minimum distance from the Snellen chart and the patient will be the 3 feet away. If the patient cannot read the letter E at 3 feet away, we move to finger counting. So when we do the finger counting, we still do it one eye at a time. We take the test at 3 feet away. If the patient cannot see the fingers and correctly identify the number of fingers that we put out, so we ask the patient, how many do you see? How many do you see? How many fingers do you see? If the patient cannot correctly identify them consistently at 3 feet, we have to ask them to move at 1 foot increments. So from 3 feet, 2 feet, and 1 foot away. If the patient read the number of fingers at 2 feet away, we record it as CF or counting fingers at 2 feet. However, if still the patient cannot see the fingers at 1 foot away, we test the hand movement with light projection test. Please mute the microphone of the one speaking if you have no question. If the patient cannot do the finger counting test, we have to move to the hand movement with light projection test. You have to do 2 exams for this step. So the hand movement will be done by testing the vision of the patient's eye by moving the fingers in front of the patient's face. You ask them if there's movement or not. So please make sure that you're doing this randomly. You can ask them, is there movement or none? Is there movement or none? Is there movement or none? You have to have them consistently say it properly or identify movement properly, because this is part of the testing. If they can see movement in front of them, please do not do it too close to their eyes and do not move your hands too fast, because what will happen is they will feel the air hitting their eyelashes and they might perceive movement even if they don't see it. After doing the hand movement exam, we do the light projection test. The light projection is done by pointing a light source in 4 quadrants. You can do this randomly in any random order. However, what's important is the patient will be able to identify where the light source is coming from. So if imagine the left eye is covered because we're testing the right eye, we point a light from the upper right and ask the patient where the light is coming from. The patient should be able to point where the light is coming from. If the patient is able to identify the 4 quadrants properly, we score it as good light projection. If the patient can only identify 2 to 3 quadrants properly, then that is fair. But if the patient can only consistently identify one area, and that is poor. So if you see here, the test results, it would be plus or minus hand movement with good, fair, or poor light projection. What if the patient cannot identify where the light is coming from, but can see light? Then we score that as light perception, not projection, but perception, meaning the patient perceives light but does not know where it's coming from. So in that case, we just write LP. If the patient still cannot ascertain if there is light or not consistently, meaning the patient can only see darkness, so we record it as NLP, or no light perception. So is there any question at this point? So moving forward, if the patient is greater than 40 to 45 years old, the patient would lose the ability to accommodate to a certain degree. That condition is called presbyopia. When the patient has presbyopia, he or she could not see what is 14 inches in front of them or closer. So usually when our parents read, they put the image farther or their smartphones farther so that they can read that. That's a sign of presbyopia. So we test it by showing them a picture chart or a Jaeger's test chart. So this is tested 14 inches away from the patient's face, and we ask them to read. So if the patient can read the letters MORN or MORN, we score that as J20. So the higher the scoring, 20, means the poorer the vision is at near. So if the patient can read the words at number 2, that means the patient has very good near vision, or J2. If you notice also on the left side of the screen, we see numbers. Those correspond to patients' ages. The adjacent column is a grade. So +1, +125, +150. Those correspond to the grades of the reading glasses we usually give to patients based on their age. So if the patient does not have or does not need corrective glasses at a distance, but only has a problem in reading at near, then it is safe to assume that if the patient is 50 years old, we would give them reading glasses with the power of +200. Okay? So if the patient is 60 years old, we give them reading glasses of +300 or +3. So those hold true if the patient does not need any distance correcting glasses. If the patient has distance correcting glasses, then we give them bifocals or multifocal glasses or progressive, such that the reading segment adds plus 100 or plus 150 or plus 300 based on their age or the power they want to use to read the things that are which are 14 inches away from their faces. Is there any question regarding visual acuity for near and distance? Because if there are none, we will move to the external examination. Any questions at this point? So if there are none, the external examination is the next part of the ocular exam. So when we do the external examination, we examine the gross appearance of the orbit, the eyelids, the lacrimal or the tear system, and the globe itself or the eyeball. When we do this, it should be systematically done from outside going to inside. It may also be inside to out, however, I prefer it being outside to in. We must appropriately describe the structure and identify the presence or absence of abnormalities. Also, we have to assess the symmetry or asymmetry of features because they could be normal, but they may not be equal. Because we have two eyes, we always have to compare one eye to the other. This is how we draw the diagram of the gross eye examination. Diagram number 1 is the inverted eyelids of the right eye. Diagram number 2 is the right eye. Diagram number 3 is the left eye, while diagram number 4 is the left everted eyelids, such that if we complete this, this is where the eyelashes are, this is where the globe is, because that is the turned upside down or outward in. This is where the eyebrows are supposed to be, and this is where the eyelashes are again. If in case the patient has, for example, a nevus or a mole near the right upper eyebrow, then it should be placed here. It should not be placed here. Because if you put it in diagram 1, that just means that the lesion is somewhere under the eyelid, in the conjunctiva. So please remember that, because for the OSCE, I should be able to see the diagram. If not, the group that does not show it most likely will fail. So we also have to check the sclera for swelling, redness, and discharge after you do the gross examination around it. The next thing to do is the Hirschberg reflex. The Hirschberg reflex is done by pointing a flashlight in front of the patient's eye. This gives us the alignment of the eye, such that if the patient's eyes are looking straight, the light reflection would hit the center of the pupil, marked with the X. So if the patient has inward deviation of the right eye, we do not draw the eye going inside. We do not draw it like this. Rather, what we do is we move the X mark. So if the right eye is deviated inward, like that, the light will hit the temporal side of the cornea. So we move the X mark. We do not draw like this. If you do that, I will give you a wrong mark. Definitely, what we have to do is we move the X. Moving forward of the gross eye examination is the pupillary exam. This is used to assess the appearance and function of the pupil. So what does the iris and pupil do? It actually limits the amount of light going inside the retina. So if you fix the amount of light going in and out of the eye, that will give you a clearer image. To test this, we have to do the direct and consensual pupillary reflex light to light test, which will be shown in the following slide. You should also be able to identify the presence or absence of the relative afferent pupillary defect, which will be shown later. So this is how we test the direct and indirect pupillary light reflex. So what happens first is we get a strong flashlight or pen light in a dimly lit room. We point the flashlight to one eye. The eye being pointed with the flashlight tests the direct pupillary light reflex. Usually what happens is the pupil should constrict to normally 3 millimeters in diameter. So we say that the pupil is 3 millimeters briskly reactive to light. If after we do that, we should also look at the other eye, even if there is no light. Normal response would be that the other eye would also constrict. That is the consensual or indirect pupillary light reflex. So if you put a flashlight on the right eye, both pupils should constrict at a certain and similar degree. So if the right eye constricts at 3 millimeters, the left eye should also constrict at 3 millimeters. That tells us that there is intact direct and indirect pupillary light reflex. After doing the right eye, we check the left eye also and see if there is direct and consensual light reflex. So we report that as 3 millimeters equally and briskly reactive to light if both pupils react the same way. The next part is a relative afferent pupillary defect. As was mentioned in the last lecture, the afferent arm is the cranial nerve 2, which tells us the vision using the optic nerve. The cranial nerve 3, on the other hand, will constrict the pupil. It will also give us the extraocular muscle movement. Okay, so the usual response to light being shown at one eye is both eyes constricting at the same time and at the same degree. However, if you see here in the animation, if the right eye has shown light, both pupils constrict. However, when the light is swung to the left eye, both pupils dilate. That just tells us that the left optic nerve or the afferent arm does not perceive as much light as the right one. So it tells us that there is an RAPD or relative afferent pupillary defect for the left eye. So that is a pathologic problem because that means the problem is in the optic nerve. And even if the patient needs eyeglasses, if we give them eyeglasses, it will not affect the vision because the optic nerve or the afferent arm is the problem. So usually, we do the RAPD testing because it is very, very, very specific to an optic nerve problem. Even if you have very thick cataracts or bleeding inside the eye, it will not give you an RAPD. Okay? So if the patient has an RAPD, that means that the problem is the optic nerve. Okay? So at this point, is there any question regarding the gross eye examination? If there's none, we move to the motility exam. No questions?
Doctor, can you repeat this again?
What?
Can you repeat the relative afferent pupillary defect again?
The relative afferent pupillary defect is a problem between the interaction between the cranial nerve 2 and cranial nerve 3. So, the normal reaction should be if light is pointed towards a specific eye, both pupils, even if not being lighted with a pen light, should react the same way. So both should constrict. If you move the light source to the other eye, both pupils should remain constricted. However, in this animation, after constricting the right eye, when the light was moved to the left pupil, both of the pupils dilated. That is an RAPD because that means the afferent arm of the left eye does not perceive as much light as the right eye. So that means there's an optic nerve problem. Did you understand that?
Yes, doctor. Thank you.
Moving forward, the next part is the motility examination. When we do a motility examination, we evaluate and describe the different actions of the extraocular muscles. We have 6 extraocular muscles per eye, 4 recti muscles, and 2 oblique muscles. We have to categorize or specifically identify if any of them have any abnormalities in eye movement. So since we have 2 eyes, we also compare each to both of them. We check for symmetry, over or under action. We also look for abnormal eye movements or misalignments. So for example, this is how we test the extraocular eye movement. We use our finger and tell them to look straight without moving their faces or heads. Follow your finger. So you have to make sure that you reach the maximum part of their eye movement. After doing that, you trace a letter H and note whether they have full vision. So if the patient is just looking straight, that's called the primary vision or primary gaze. If you tell the patient to follow your finger to the right side, we are actually testing the right lateral rectus and the left medial rectus. And then if you move them to the left side, that is the left lateral rectus and the right medial rectus. If you tell them to move to the upper right, that becomes the right superior rectus and the left inferior oblique. If lower right, that is the right inferior rectus, left superior oblique, and so on and so forth. So that is how we test it. We draw a letter H to test all their movements. We do not need to put our finger in the 12 o'clock and 6 o'clock position because you will be testing 2 muscles per eye and that will just confuse you. We have to make sure that we test 1 muscle per eye so that we will be able to identify what the problem is. Remember, each muscle has its own innervation. So the lateral rectus is innervated by the cranial nerve 6. The superior oblique is innervated by the cranial nerve 4. And all other muscles are innervated by cranial nerve 3. When we do the test, we usually do the test together with both eyes open. So if there are no problems, we do not need to test the eyes individually. If we test the eyes together, that's called the Vergen's test. But if we do it one at a time, it's the Duction test. Usually, as I told you a while ago, if both eyes move fully and equally, then we only need to do the Vergen's test and we don't have to do the Ductions. This is how we draw it. So this is the Vergen's test with both eyes open. The one on the square is the Duction test, meaning 1 eye at a time. When we do this, if you notice, there is an arrowhead and a circle. The arrowhead denotes the right eye. The circle denotes the left eye. The bars at the end tell us that it reached the maximum movement. Okay? If the patient has a problem in the movement when we do the Vergen's test, it is necessary for us to do the Duction test, 1 eye at a time. So if you notice, this one is limited. So the left lateral rectus does not move until the end. So we test if the problem is really the right eye or the left eye. It is very possible that even if the left lateral rectus is the one that's not moving, it may be a problem of the right medial rectus. meaning because the right medial rectus has already reached the apex, that means the left lateral rectus, the left lateral rectus, even if it could do it, because the right eye is dominant, it tells the brain to stop. So we have to do one eye at a time. So we see here that when we did the right eye, all muscle movements are full. However, when we did the left eye, it did not reach. So it is still very much weak. In this case, the patient has a lateral rectus weakness, and this can be due to a cranial nerve 6 palsy. Since, as was mentioned a while ago, the cranial nerve of the lateral rectus is cranial nerve 6. Okay? So, if we check and we see that there is weakness in the movement, we have to grade it. The usual maximum movement is graded as 4/4. However, if it is limited, we can divide the arrow or the line into 4 equal parts. So if we notice here, as I draw it, the first one is 1/4, the next is 2/4, 3/4, and 4/4, which is maximum. If we see that the movement did not reach the maximum movement but has crossed half of the movement, then we can say that the score is 3/4. Okay? So that's how we report. We say that the left lateral rectus movement, or EOM, is 3/4, meaning the patient has a left cranial nerve 6 palsy. Does anyone have any question at this point? If none, we are moving towards the visual field exam. The visual field, any questions?
Just please go back over the 4/4 and 3/4. The last section where you were talking about the grading system.
I just drew it. It's not part of it.
No, I mean the grading with the 4/4 and the 3/0. I just want the explanation for that.
As mentioned a while ago, the weakness, I'll be giving this PowerPoint, however, a lot of this was discussed by me only. It's not part of the slides, so please listen. I can divide it into 4 equal parts. If the movement will only reach here, then that is graded 3/4. The maximum movement, such as this one, is 4/4. Okay? Is there any question? Or that was already clear? Is it clear?
Sure. Thank you. Thank you.
For the visual field examination, when we do visual field exams, we should make sure we see what the patient sees. Each individual should at least see 30 degrees of vision. So when we assess this, there are crude techniques or high-tech machines. The crude technique will be the one that you have to show here. We have to observe and identify the common categories of the visual field defects because this will tell us the pathology on the nervous system. Different parts of the optic tract, as was mentioned in the previous lecture, will give us different manifestations of visual field cuts or weakness in vision. So this is how we do the confrontation testing. I am including a link of a YouTube video here, which you should watch on your free time. If you notice, the left eye on this diagram corresponds to the left side and the right eye corresponds to the right side, unlike the other parts of the test, because here we record what the patient sees. So, in case our patient has a lesion or a problem here on the number 1, which is the optic nerve, it will manifest as poor vision or visual field cut of the entire right eye. However, if the patient has a problem in the optic chiasm, here in the area labeled as number 2, the patient will have a bitemporal hemianopia, meaning the patient can still see well. However, the visual fields on the right and left lateral areas will be compromised depending on the eye. So it's really the temporal side of each eye which will get affected. So each visual field will correspond to a specific lesion. It's just like in neurology. Each organ has its own innervation. Given that there's a weakness or problem in that organ, it will tell us where the lesion may be. So that's the importance of why we do the visual field testing using the confrontation test. Please watch it again in the video link below. I will be sending the PowerPoint to each one so that you can review this for your OSCE. The next part is the tonometry. The tonometry will tell us the hardness or softness of the eye. So if we notice that the patient has a hard or hypertonic eye, it will tell us that there may be increased intraocular pressure, which may be a clue for glaucoma. So usually, if you notice here in the picture, this is a Goldmann applanation tonometer. This is the gold standard in taking the intraocular pressure. But if you do not have a Goldmann applanation tonometer, we can use the two fingers, the two index fingers, as the digital tonometry. So what we do is we put both index fingers over the patient's globe and palpate. One index finger is used to stabilize the globe, while the other index finger is used to palpate the tone. So when we do this, we ask the patient to look downwards because we are palpating the scleral pressure. We do not do the digital tonometry over the cornea because it will give us wrong results. Unlike the Goldmann applanation tonometer, which measures the corneal, the intraocular pressure through the cornea, when we do the digital tonometry, we palpate over the sclera. Please make sure that the patient is not closing their eyes, because if they close their eyes, because of the Bell's phenomena, the cornea or the eyes will point upwards. If we do that, we get the corneal pressure. So tell the patient to look downwards when you do this. The normal finding is soft, which is the consistency of the lips. That's what you should palpate. That's how it should feel when you do the digital tonometry. However, if the palpated eye or globe gives you the consistency of the tip of your nose, that means it is firm, and it may point you towards a problem with the intraocular pressure. Increased intraocular pressure, which was, as mentioned a while ago, may point you to the diagnosis of glaucoma. Any questions at this point? Moving forward, the next part of the ocular examination is the fundoscopic exam. That is examination of the retina using an ophthalmoscope. If you notice here in the right side of the slide, we can see two instruments. The one above is a direct ophthalmoscope, while the one below is an indirect ophthalmoscope. For your OSCE, we only need the direct ophthalmoscope. Please watch the video with the link below on your free time because this is what you should explain. When you look through the fundus through a direct ophthalmoscope, this is what you see. This one is the right eye, and this one is the left eye. If you notice, the optic nerve is nasal or nearer the nose, while the macula or the fovea is temporal or towards the ear. The macula is 2.5 disc diameters from the optic nerve and 1/2 disc diameter inferior from the optic nerve. So the macula should be temporal and lower. So if you notice here, both of these are normal findings. When you do direct ophthalmoscope, you have to make sure that you're in a dimly lit room and approach the patient from the temporal side of the face. When you check the patient's right eye, you should be using your right eye, because if you use your left eye to check the patient's right eye, both of your noses will hit each other. When doing the direct ophthalmoscopy, it is very, very close to each other. So make sure that you are using your right eye to check the patient's right eye. When you do this, when you approach the patient from the temporal area, the first thing you'll see is the nasal side. You won't be able to see the whole retina like this photo, because this is a dilated exam using an indirect technique. But since we're using direct ophthalmoscopy, you'll only be able to see certain areas and only a parcel of what we have to see. So this is the first thing you see, the nasal arcade or the nasal side. You have to make sure that you see the red-orange reflex or the color of the retina, and you'll be able to see a blood vessel. Once you see a blood vessel, trace it. So when you trace it, when you move towards the patient's face from the temporal area, when you trace it, the next thing you see is the optic nerve. When you see the optic nerve, you must characterize if you see distinct disc borders, meaning you see the optic nerve with good distinct borders. It's very, very circular and it does not look fuzzy. So that's the next report that you would do, distinct disc borders, followed by looking at the optic disc and optic cup. The optic disc is the outer portion of the optic nerve, while the optic cup is the smaller, paler central. So the next thing you categorize or define is the cup disc ratio. The cup disc ratio is the ratio between the optic nerve, the optic cup of the optic nerve, and the optic disc. The usual finding is 0.3 or 0.4. If you have a cup disc ratio of greater than 0.5, that will point you towards a diagnosis of glaucoma. After doing the cup disc ratio, you look at the blood vessels. So these ones. These are the arteries or arterioles, and these are the venules. If you notice, the arterioles are less red compared to the venule, which has this deoxygenized blood, and the venules are thicker or wider than the arterioles. The usual AV ratio or the comparison between the thickness of the vessels should be 2:3, meaning the venules are bigger than the artery. The artery is a 2, the venule is a 3. So 2:3. If you see that the artery is only half the size or thickness of the venule, then you score it as an AV ratio of 1:2. That points you to a diagnosis of hypertensive retinopathy. After looking at the blood vessel thickness, you look around the blood vessels if you notice bleeding. If there are bleeding, you report that you see hemorrhages and possibly exudates. As shown a while ago in the previous slides, the patient had diabetic retinopathy and hypertensive retinopathy, such that we see blood clots around the eye and also exudates. So that's the next thing you have to report: presence or absence of hemorrhages and exudates. After characterizing the blood vessels, you look towards the fovea or the macula. The next report should be a good foveal reflex. A foveal reflex can be stated that it is good if you see that there is a central depression. If the fovea does not look distinct or it looks fuzzy or muffled, then that is not a good foveal reflex or dull foveal reflex. The last part would be to characterize if the retina is attached or not. If you notice, the blood vessels per eye follow a certain configuration. They have arcs or arcuate arcades, vascular arcades. So they should follow this anatomy or architecture. If in case there are kinking of blood vessels, changing or abrupt change in color, or at times you can see that the retina is lifted, then you say that the retina is detached. How we draw it using the diagram. So this is the optic nerve. These are the arcades, the vascular arcades. The X marks the macula. And this is how we say it. So as mentioned a while ago, from the nasal side, because you're approaching from the temporal side, we see the red-orange reflex. The clear media just tells us that we can see through. So there's no cataract, or the cataract is not thick and there's no bleeding. The next part is distinct disc border, meaning the optic nerve, we see that it's really circular. The cup disc ratio, as mentioned a while ago, is the ratio of the optic cup, which is the paler central portion, compared to the optic disc, which is the outer portion of the optic nerve. The usual finding is 0.3 or 0.4. If we have a cup disc ratio of greater than 0.5, that means that it's possible that we have glaucoma. The next part is the AV ratio, or comparing the arteries and the veins. Usually the finding should be 2:3. If we have an AV ratio of 1:3 or 1:2, that points us to a diagnosis of hypertensive retinopathy. You then trace the vascularizations, and look if there are presence or absence of hemorrhages and exudates, because the presence of hemorrhages and exudates might point you to a diagnosis of hypertensive retinopathy if there are a lot of exudates, hard exudates in particular, or diabetic retinopathy if you see soft or cotton wool exudates and bleeding around the vessels. The last thing you look at is the foveal reflex, marked with the X, because the foveal reflex is in the macula. If it is, if there's a central punctum or it is well defined, then we say that it's a good foveal reflex. If we see that it is blunted or does not have a central punctum, then we say it is dull. The last part is that the retina is attached. So any questions regarding the whole physical and the ophthalmic history and physical examination?
Doctor, can you say me about DDB?
What?
The disc border DDB.
Again, your voice is muffled.
Doctor, can you say me about the DDB, the disc border? You just explained right now. Distinct
This is the disc border. So you notice that the disc, the optic disc, is well defined. It is very circular. If the disc border looks like a star shape or it looks like sunburst, then that is indistinct disc border. An indistinct disc border points towards papilledema. But if you see that it's very circular, like this, it is distinct. Okay?
Yes, doctor. Thank you.
So if there are no questions, the evaluation of Module 2, you have to form 5 groups per class. So as mentioned a while ago, we have 2 groups, 2 big groups per class, and we have to have 5 groups per class. So an overall number of 10 groups. We have to create a 5-minute video, or it's okay if it's 10 minutes, 5 to 10 minute video of a specific ophthalmologic physical exam discussed here. I will be giving the cases and the specifications or specifics per case. The video can be an animation, acting out, or you can just be really creative. it should involve an examiner and a patient. So there are instructions per group. So you should show the normal findings and abnormal findings. Each case has a question as well. So this must include a report and a graphical diagram of the findings, not just the video, but also a write-up of it. So I'll be showing the case. Are there any questions at this point?
Doctor, for the OSCE, should everyone in the group be involved in the video or just the one or two members?
It's best that everyone has their thing to do because, as I mentioned a while ago, I failed the whole group because not everyone checked what it was. So even if they have a very high scorer or one of them is an honor student, the student failed because it was a group grade. So make sure that everyone sees what you do, what each one of you does, because if not, it's possible that the group grade may not be applicable to you. But since you did not check the output, you might fail. So these are the cases. I will be sending it also to, I'll also be sending it to your group. Oh, wait a moment. I'll also be sending it to the group, but I will explain first so that there is no confusion in the output. So please group yourself alphabetically. For the group 1, you should be testing the visual acuity using a Snellen chart with the findings of normal to 3/200, moving towards counting fingers, hand movement with light projection, light perception, and no light perception, also the near visual acuity. You should explain all the normal and abnormal findings. For group 2 is a gross examination with the pupil exam, with direct and indirect pupillary light reflexes, RAPD, and demonstrate a diagram of a case of a patient with 30 degrees esotropia of the right eye with an orthophoric left eye. For group 3, it's a motility examination with a case of cranial nerve 3 palsy. Show both diagrams and explanations with the nerve and muscle connections. For group 4 is the tonometry and visual confrontation test. Explain how the Goldmann applanation tonometer works and demonstrate how to do the digital tonometry while annotating what the student is doing. For the confrontation test, demonstrate how confrontation test is being done properly and illustrate and explain how the pie on the floor visual field defect is caused. For group 5, explain the differences of the direct and indirect ophthalmoscopy, demonstrate how to properly do the direct ophthalmoscopy, and include photos of the following conditions and pertinent fundoscopy findings of non-proliferative and proliferative diabetic retinopathy, glaucomatous optic neuropathy, ocular toxocariasis, retinoblastoma, and uveitis. So I'll be sending the cases to the LO. Please make sure that everyone does their thing because I will expect that after I read or watch the video and read the paper that everyone pitched in. So if it is okay with the group, when you pass it, then I give you the same grade each. Because before, even if there were 3 honor students in a group of 25, all of them failed the module. So make sure that everyone does their part and checks the output. You still have until Tuesday next week by 1 p.m. to submit the videos. And then I will be announcing who moves forward to the next modules and who does not. At this point, we have 2 failing marks in the exam. I will talk to the 2 who failed and give them a repeat examination. If they pass and then they move forward, but if they fail, they won't move towards the next couple of modules. Any questions at this point?
Yes,
Doctor,
doctor, question, please.
can we extend the date of submission, doctor, from Tuesday to Thursday, if possible?
No, because Thursday you'll already be moved towards the next module.
Okay.
So the
Okay.
ones who do not pass on Wednesday will not move towards the next couple of modules. As mentioned a while ago, I'm the only one who will be the prerequisite for the next modules. If you do not pass my module, no one moves. Okay?
Doctor,
Since this is only a 5 to 10 minute presentation and each physical examination is divided and not the whole OSCE, I expect that this would be done fast and properly. Also, the write-up should be okay because it's very possible that you do not do the video properly but the write-up is okay. If there are signs of plagiarism, that will be an automatic failure for the whole group. Any questions?
yeah, doctor. I'm more concerned with the groupings. Since it's 2 groups, they have session A and session B, and in each group there's 5 subgroups. So
Yes.
those 5 subgroups, is it that we can select our group members so we
No,
know?
do it alphabetically.
Because you really strict with this rule, so I was also thinking about my output and my grades as well. So that's why I asked you.
Yes, that's why all of you should work properly.
But doctor, it's difficult to work with people who don't, really don't want to put in time, right?
If they do not do or do not participate, you mark it on the write-up and I will fail the person.
And the burden still falls on me, and I have a lot of things to also catch up with, like other courses. So that was the point. That was my point. It's not about them failing alone, but also for me to be having time to do the other works, like other school works. That was my point.
Well, do you have to be in the school now? You all have a lot of time. And in the normal sense, you'd already be doing the OSCE the next day in the clinics. But you are given until Tuesday. So I do not see any reason for you not to do it. Remember, you are doctors. Doctors do not have schedules. We have emergencies. We have life-threatening conditions. And you do not have any reason not to give it on time. You are given Thursday, Friday, Saturday, Sunday, Monday, and Tuesday. That's a good 6 days. So I do not see any reason for you or your group to not submit on time. Any questions?
Doctor, for the OSCE video, can we use can we take videos from other places if we are not able to show a certain examination, or is it important that a student has to be performing those examinations?
It's important for the examination to be done, but for the other cases which I mentioned here, you should be able to show it in a diagram. That's why the diagrams were explained a while ago, because it should be reported as such. But most of it, you could do it on a patient or on a classmate. Any more questions?
The work is divided like basically into 2 portions, right? Where there's a video and there's a written document, right? So if somebody doesn't appear in the video, they can do the written document. It's still counted for, or you must be in the video as well as participate in the written document.
No, it's counted I will be giving the whole group the same grade. So the output of the video and the written report will be the same for everyone. So as long as the person contributed to any of the outputs, it would be considered a group grade. So that's where you can fix how you're going to do the division of labor.
Thank you.
Any further questions?
Doctor, one more question.
What?
Regarding the written report, do you have any further instructions as to the length of the report or any other specifications that you'd like to give us for the written report?
No particular instructions on that. You just have to make sure that you answered my questions in the grouping, in the expected outputs of the video. If I see any signs of plagiarism, I would fail the group as well. I've already done that for a previous group. So please make sure you do it properly. We use software to counter check.
Thank you, Doctor. And about the submission, are we expected to upload a link somewhere, or are we supposed to mail it to you directly, Po?
The LO will compile all the links in the Google Drive that is accessible by me, and I'll be reviewing that on Tuesday. So by 1 p.m., it should be sent to me, the Google links.
Unfortunately, we don't have a Moodle account.
You just send it here. Google links.
Okay.
Google Drive. So I'm expecting 10 submissions, including the names of the members. If the member is not included in any list, I will automatically fail that person. So make sure that everyone is documented in the groupings. If not, then that means you're not part of the group. Any more questions?
Doctor, do we need to use the instruments like for thermoscope or something?
It was all based on my lecture. So you just need to show what is shown here. And if you want to add something else, then it's fine by me. But if you put unnecessary things, it will be a point against you.
Okay, thank you.
Any more questions? If not, class dismissed. I expect the links from the liaison officer by 1 p.m. on Tuesday. I'll be sending the PowerPoint in this MS Team with the groupings, with the cases per group. Thank you.
Sure, Doctor. Thank you.